I'm very honored to receive the Pan American Society of Clinical Virology Diagnostic Virology Award for 2021. To be in the company of the likes of Stephen Spector, Mari Lanray, Rick Hodinka, Greg Stock, and others is truly a great honor. They have been a source of inspiration and advice over the past many years. The forerunner of the Pan American Society of Clinical Virology was the Pan American Group for Rapid Virus Diagnosis, initiated in the 1970s to promote the advances in rapid virus diagnosis. Although it may be difficult to imagine this today, prior to these initiatives, clinical virology was largely a retrospective exercise based on virus culture and paired serology. Philip Gardner and Joyce McQuillan at the Royal Victoria Infirmary, Newcastle upon Tyne in England, were pioneers of the use of immunofluorescence for rapid virus diagnosis. I myself was born in Sri Lanka, received my medical training there, and was fortunate to do part of my clinical virology training and subsequently to work as a clinical virologist at the Royal Victoria Infirmary in Newcastle upon Tyne in the 1980s, when Joyce McQuillan was still working there. Later, when I took on the task of setting up a diagnostic clinical virology laboratory at the Queen Mary Hospital in Hong Kong in 1995, the annual meetings of the Pan American Society of Clinical Virology were a major source of inspiration for me. I was a regular attendee at the April-May meetings at Clearwater Beach, Florida, and I recall my first meeting there when I hardly knew anybody, when Stephen Spector came up and had a chat with me. This illustrated for me the spirit and collegiality of this meeting. I also recall, I think, in the 1996 meeting, when the question of how we can document the cost effectiveness of clinical virology was discussed, so that hospital administrators can be convinced of its value. Mulling over this on the flight back to Hong Kong, it dawned on me that since I was just introducing rapid diagnosis of respiratory virus infections at my laboratory in Hong Kong, this was an opportunity to address this question. At this time, in fact, some of my hospital colleagues in Hong Kong were asking why we were wasting resources on rapid diagnosis of respiratory diseases, because there were very few antivirals and vaccines other than for influenza, and nothing specific could be done for these other viruses. So I had a strong motive to address this question. We indeed carried out such a study, and we showed that the introduction of rapid respiratory virus diagnosis in our hospital reduced hospital stay, reduced antibiotic use, and was associated with significant cost savings for healthcare. This was published the next year in the Journal of Clinical Microbiology, but more importantly, it was very useful data for me to use to convince skeptical colleagues in Hong Kong of the value of rapid respiratory virus diagnosis. By the end of 1997, avian influenza H5N1 caused an outbreak in Hong Kong. And this dispelled any lingering doubts about the value of rapid virus diagnosis, specifically rapid diagnosis of respiratory virus infections. Within a few years, our laboratory was at the epicenter of the SARS outbreak in 2003, where we contributed to identifying the causative agent to be a novel coronavirus, developing RT-PCR diagnostic tests for SARS coronavirus, characterizing the clinical virology of the disease, and identifying wild game animal markets in southern China as the interface where the zoonotic spillover occurred. This last finding led to the closure of these wild game animal markets in Guangdong, thereby very likely averting the re-emergence of SARS from this source. In subsequent years, my work focused more on research on zoonotic influenza and on coronaviruses such as SARS and MERS. The focus of my work also shifted to the animal-human interface, where many of these viruses emerged from, and to using a One Health approach to emerging virus disease threats by collaborating with animal health and environmental scientists, as well as public health authorities. By understanding the pathways of spillover of avian influenza viruses to humans, we succeeded in introducing interventions in the live poultry marketing chain that significantly reduced risk of zoonotic influenza in Hong Kong. Indeed, since 1997, since that outbreak of avian flu, we in Hong Kong have not had a single local case of severe zoonotic avian influenza emerging within Hong Kong. Although surrounding regions continued to be challenged by a series of zoonotic influenza virus outbreaks, such as H5N1, H7N9, and others over the years. With this change of focus, my attendance at the Pan-American Society of Clinical Virology meetings had become less regular and frequent. But this organization remains very much close to my heart, and it was crucial to the start of my career in clinical virology. Thank you again very much for this recognition and honor.